This is literally going to be the best podcast you've ever seen in your entire life in regards to diabetes. Cue the music. Hello, podcasting world, and welcome back to the Core Console RX podcast. My name's Mike Corvino. With me, as always, is Cole Swanson. Cole, what's up, man?
Doing great. It's the first day of spring today. Pretty
Is it?
excited. Yeah, it's freezing.
It is very cold, which is weird for South Carolina.
Pretty excited to be in our brand new recording studio.
Yes. For those of you who are watching the video version of this and you're like, wait a minute, that looks just like the old recording studio. That's because it is. The table that we had ordered for the new podcasting studio apparently was damaged in transit. So they sent it back to wherever it came from, and we still have no podcasting room.
But it's okay.
It's all right.
It's in progress. So.
It is. It's in progress. It's going to be cool, I think.
Yeah.
And if not, we'll try again later. Right. Keep improving. All right. So today we are going to be covering some diabetes management because if you have not seen, hopefully you have, there is yet another set of guidelines for treating someone with type 2 diabetes. So we had the ACE guidelines, we had the ADA. Now we have the American College of Physicians have thrown their hat into the ring, which I guess they've had guidelines, but these are the 2018 updated guidelines. And the good thing is they all conflict each other. So now we will go through and figure out when to use what or what makes sense or why the guidelines are the way they are.
Yeah, and to me, I find it pretty surprising that we could have all this data in diabetes patients and still not have a consensus on what the best A1C goal is for patients. And I think it's because if there was anything that ever needed to be really individualized, it's A1C goals. Really is patient specific if there ever was something that needed to be patient specific.
Yeah, for sure. I agree. So we're going to go run through a short patient case, talk about maybe some treatment options, and then we'll kind of use that to jump into how we would use one of those sets of guidelines or a combination of all three, or how we could look at it.
Yeah, we'll kind of frame the main points of the new ACP update, and then we'll talk about how it differs from the other two, because it definitely does.
Exactly. So anything you want to cover before we get into the...
No, you can throw it out. We can start with that. We'll front load them with a case.
Whew, you guys are so lucky. Front loading with a case. All right, so KJ is a 67-year-old white male that presents for diabetes management follow-up. He has a past medical history of type 2 diabetes, hypertension, and dyslipidemia. His current A1C is 8.4%. He does have a microalbuminuria of 95 milligrams per deciliter. Other labs that we would care about are within normal limits. His home meds include metformin, 1,000 milligrams. He's taking 500 milligrams twice a day. Also on amlodipine, 10 milligrams once a day for his blood pressure, and atorvastatin, 80 milligrams.
Yeah, so what we got here is a pretty standard diabetes patient. He is a little older, 67 years old, A1C is 8.4, but otherwise he's got hypertension and dyslipidemia, which pretty much all patients with diabetes are going to have. So the question is, what's his A1C goal? Do we go down to 6.5 like the ACE guidelines might recommend? Is he less than 7 like the ADA guidelines recommend? Or, spoiler alert, is it between 7 and 8 like the ACP guidelines recommend? And not spoiler because that's what we're recommending, but spoiler because that's what the ACP are recommending.
Yes, exactly. So typically speaking, when we think about guidelines, we're thinking about the ACE, which, like Cole said, less than 6.5 rather, and then the ADA being less than 7. So the new guidelines that give that range, they claim that it's evidence-based. So we want to talk about some of the trials that are responsible for them drawing that conclusion, and then maybe why the less than 7 goal is still with the ADA, and then we will maybe attempt to justify the ACE guidelines, which right. I'm personally not a huge fan of that low of an A1C for a type 2, but we'll see.
So let's back up really quick. So the ACP put out 4 essentially guidance statements that is kind of the update of their recommendations. And the first one, which really all of the guidelines do mention, is that clinicians need to personalize the glycemic control, so personalize the A1C goal, and there's a lot of factors that go into it. Age, comorbidities, how they're responding to treatment, what their A1C is when they're first diagnosed, and where their A1C is right now. And so they do make that caveat, even though they're recommending an A1C level between 7 and 8 for most patients, they say.
Exactly. So do you want to start off with the trial? You want me to take over the first one?
Yeah, I can go through the first one. So the first one, just briefly, is the Accord trial, which most people have heard of. And I think a lot of people have a bad taste in their mouth about the Accord trial, and that's because the results weren't that positive. So they were looking at more intensive intensive glycemic control. So in A1C, they were going for less than 6 in the intensive group. And then was it less than 7 in the non-intensive group?
Yes, standard therapy was 7. It was 7.0 to 7.9.
Right. So between 7 and 8, which is what these ACP guidelines are recommending, they didn't actually get to less than 6 in the intensive treatment group. They only got to 6.4. And the reason for that is because the trial had to be stopped early because the outcomes weren't very good. They were seeing a lot of adverse events in the intensive group, a lot more hypoglycemia, and they saw an increased risk for death. And I think it was a 22% relative increased risk of death compared to the non-intensive group. So that's not that great. So there's, I would say, one mark against shooting for at least a super low A1C, less than 6, or more specifically, less than 6.5.
Yeah, and it's anytime you see increase in death, that's just usually a good fact, like indicator that maybe it's not a great treatment option. But
yeah,
that's just
that's not evidence based, but yes, it is. And that kind of goes to the third guidance statement of the ACP guidelines. They recommend de-intensifying therapy if a patient's A1C is less than 6.5, and that's almost exclusively based on the Accord trial, where they saw the increased risk of death for those patients who were at an average A1C of 6.4. And it seems reasonable to me. You know, if I have a patient who I see is on a lot of meds, especially if it's sulfonylureas and insulin, which are high risk for hypoglycemia, I might be like, all right, we can probably de-intensify a little bit, and, relax their control, especially if they're having symptoms.
Exactly. So another trial that was published was the Advanced trial, and they were also looking at A1C goals, intensive versus standard. And what they saw was that there wasn't really a difference between the two goals and the outcomes. So they used a intensive goal of less than 6.5, and they did achieve right at 6.5. In the standard treatment, they achieved a goal of 7.3. No reduction in macrovascular events. So there was a little bit of a increased benefit with the intensive control as far as microvascular, but the microvascular events seem to be driven by the neuropathy benefit. So a little bit more benefit with neuropathy, which I guess in this guy's case, he's got a little bit of a macroalbuminuria going on, so we could discuss that.
Right.
But the lower target did also didn't affect like the creatinine doubling or some of the other kidney function, renal function goals they were looking at. So we have the Accord trial showing negative outcomes and harm with lower A1C goals. Now we have the Advanced trial showing as far as macrovascular, which is what a lot of times what we're really worried about.
Cardiovascular events was the biggest thing you're really thinking about. Stroke, MI,
the whole death thing.
Yeah, that whole thing.
This one's showing no benefit, and so that's two of our big trials that we'll hear quoted. You want to go through UKPDS?
Yeah, and a couple things too about the Advanced. So that was over 5 years, and you'll see that the timetable for benefit is important. And that is a consideration with what you think your patient's current predicted lifespan is at this point. And also with the Advance, of course, they saw more severe hypoglycemic events in the intensive group and more minor hypoglycemic events. Both of those were statistically significant. So that's definitely something to consider.
Cole's always trying to emphasize the adverse effects and trying to put a negative spin on things.
Well, gotta consider it. Consider it.
That's good. That's keeping me honest, because I totally skipped over that. So that's good. So UKPDS, Cole, what's that about?
Yeah, so it was a relatively large study. It had about 3,800 patients, average of about 54 years old. They were targeting fasting plasma, or they're targeting blood glucose levels of 108, and they were able to obtain A1Cs around 7. So this isn't nearly as intense as the Accord or the Advanced trial. And that was in the more intensive treatment group. And the less intensive, they had a mean A1C of about 7.9. So right on the upper limit of where the ACP guidelines are recommending. So this is a trial that really kind of looked at, okay, so within that 7 to 8 range, what's better? And this was like a 10-year follow-up, so it was a little bit longer. And the intensive group did show benefit in any diabetes-related endpoint. They said the absolute difference was about 5.1 events in 1,000 patient years, but it was mostly due to the microvascular endpoints. So again, not so much with the macrovascular. And a lot of this is, these are the trials that the ACP has picked out so that they can, of course, make their point and defend their A1C goal. Some of these trials, there's a little more nuances to them. You've got to consider what the patient was on, right? So a lot of these trials, patients are on a lot of sulfonylureas. They're on insulin. Some of them, they're on metformin. But nowadays, we have GLP-1s, which weren't really included in these trials, which are much safer when it comes to hypoglycemia. So if I have a patient who has an A1C of 6.9, let's say, I'm a lot less concerned about him if he's on metformin and GLP-1 than if he's on a sulfonylurea and insulin, because they're much higher risk for hypoglycemia. So that's just something to consider. So I think I definitely got off topic there.
No, that's good. That's good.
But they didn't find any mortality benefit. Diabetes-related death, all-cause mortality, MI, stroke, and whatnot. So yeah, that was over just the first 10 years of that study.
And so the other study that we'll talk about is the VADT. Again, compared the intensive versus standard. Basically, the summary is that you didn't see any difference in that group either. And that was looking at patients. It was in a veteran population, and they got a little bit of benefit as far as the cardiovascular, like the nephropathy and risk was decreased a little bit, but the macrovascular, there was no difference. And so those are the 4 trials that the new ACP guidelines use to justify their recommendation for that 7 to 8 in certain patient populations, especially elderly.
Yeah, and I should mention with the UKPDS, it's kind of split into 2 groups, essentially, right? So the 33 and the 34. The 33 was what I was talking about, but there's also the 34 where they had some different A1C goals, UKPDS 34. Median in the intensive group was like 7.4, and in the non-intensive group, it was more around 8. And they did see some benefit in that one. Metformin was kind of the driver for the benefit. And on an extended follow-up of around 17 years, that's where they started to see reductions in all-cause mortality and reductions in more diabetes-related endpoints. So that's where you really start seeing the benefit is long-term. And that's where they kind of talk about the legacy effect of metformin. The earlier you get it on, the more benefit that it has down the road. And that's also why you need to consider, okay, so how long do I really think my patient's going to live? If they're only, have a life expectancy of 8 years, they might not see the full benefit of a really intensive A1C therapy that might take 10 or 17 years to really see.
Exactly. And if we're pushing these patients, we're creating more of pushing them to lower A1Cs, we're creating more of a burden as far as taking more meds, having to pay for these meds, even with Medicare coverage, if they go into the donut hole or something like that, or if it's a younger patient that doesn't have insurance or has, insurance is not that great, it can put a financial burden on these patients. And like Cole said, if you're not really expecting them to live or past that 17-year mark or, longer to see this benefit with intensive glucose or intensive A1C lowering, are we really helping them, or are we actually kind of giving them a worse quality of life, so to speak? So that's where the debate is, and I think it's justified. I think that to say that, oh, it's just less than 7 for every patient, I think is a little short-sighted. I am very glad that the new guidelines, ACP, started off their very first recommendation with it needs to be patient-specific, and we need to consider the patient as an individual before we just give a set goal. And I think that's super, super, super important. Yeah, I just don't think that, I mean, guidelines are great, but especially with something like A1C, it's really something you have to consider all the different variables.
For sure. And it probably sounds like we're backing the ACP guidelines right now, which we're not necessarily, for me at least. It's still kind of up in the air, and it really just depends on the patient. Because ADA, like we said, was mostly across the board shooting for less than 7. And, there might be a patient that is less than 7 is good for them, and they're not having symptoms, and they have a long life expectancy and not a lot of other comorbidities, so you feel comfortable getting them there. But this kind of speaks to the 4th guidance statement from the ACP that they put out, which is basically saying anyone with a lot of comorbidities or minimal life expectancy, don't treat to a target A1C. They're saying, or actually, I should say specifically a life expectancy less than 10 years, don't treat to a target A1C, only minimize symptoms related to hyperglycemia. So they cite advanced age, which they consider 80 years or older, or if they have chronic conditions like dementia, cancer, end-stage renal disease, like severe COPD or severe congestive heart failure, they're saying don't even worry about the A1C. If they're having symptoms from their hyperglycemia, then you should treat that, but otherwise don't worry about it. So that's interesting. And it's easy to say, okay, you have diabetes, let's knock you less than 7, here's some more meds, move on to the next patient. I think that making it patient specific takes a little more thought and consideration, and sometimes talking to the patient to figure out what's going to be best. So I think that is an interesting recommendation.
Yeah, and I think, as far as backing one of them, I'm personally kind of a hybrid between ADA and the new ACP, I think, is where I would probably put myself.
Yeah.
Because some people hated the new recommendations and thought they were ridiculous that the ACP put out. And I think they honestly make a lot of sense, especially when you realize that the trials that they're talking about actually never reached goal A1Cs anyway. And you start seeing that, the standard only met 7.5, and VADT, which I didn't mention, they were, I think 8.4 was all they got to in the standard. So when you start realizing that the average A1C was actually a lot higher than they anticipated, that it's one of those things that I think it actually makes sense what they're recommending.
Yeah, which it was a big turn for me because in school, everything's very black and white. So it was really easy to say, okay, they have diabetes. What's your goal A1C? Less than 7, because at that point, we're trying to figure out what in the world an A1C means, which, by the way, if you're wondering, is the essentially the average blood glucose that a patient has had over about 3 months or so. So it's just a little more of a longitudinal picture of where their diabetes is at, as opposed to a finger stick blood glucose test right there.
Yes. So let's say for this patient, his A1C is 8.4 right now. Let's say we'll take a hybrid of the two guidelines, the ADA and the ACP. So we'll say less than 7.5. Is that agreeable?
Seems reasonable.
Seems reasonable. Doesn't have a lot of other health conditions going on other than hypertension, diabetes. Dyslipidemia it seems to be under control. So A1C 7.5.
But like you said, I think they want that number and say, okay, well, where do I need to get to? But say his A1C's 13 and this guy's in the exact same situation. You might not throw 7.5 at him right now because he'd be like, oh man, that is daunting. I don't know if I can do that, and get discouraged. So you have to set reasonable goals for that time, but the goals can vary depending on what kind of progress the patient's making. You know what I mean?
Exactly.
So
if we did say 7.5, then the question is, what medication are we going to add on? Because he's not really to the point where I would be pushing for insulin, especially in someone who's 67 and he's already on metformin. One option would be to maximize the metformin dose. He's only on 500 milligrams twice a day, and we could give him 1,000 milligrams twice a day as long as he can tolerate the GI effects of that and push him up that way. However, we're probably not going to get to A1C goal just by doing that. I would still say maximize the metformin just for the potential cardiovascular benefits, but as far as getting that almost a full percentage point down, then I think we're going to need a second agent. So I am a huge fan, if I'm not going to use insulin, a huge fan of GLP-1s. As long as the patient can afford them, their insurance covers them, I am a big advocate for GLP-1s. So just to kind of review, GLP-1s work on a few different mechanisms. So the first one, obviously, is that there's GLP-1 receptors around the pancreas, so that if GLP-1 binds, because it's an analog, if it binds, it will stimulate the beta cells to start producing insulin. At the same time, it can also bind on those receptors and then cause alpha cells to decrease the production of glucagon. So right away, if you have a decrease in glucagon, you're going to stop gluconeogenesis, you're going to stop glycogenolysis, and you're getting an increase in insulin, so you're going to get an uptake of that blood glucose and driving it down, or driving down the blood glucose levels. So the other benefit to that, and because there's other agents we can use, obviously, to bring the levels down, but like for sulfonylurea, for example, if I take a sulfonylurea in the morning and I don't eat, my blood sugar is going to go down whether I like it or not. It's probably going to be lower than I anticipated because I didn't eat a meal. Right. And that's where we see all the hypoglycemic events with something like sulfonylureas. And with GLP-1s, then we get what they call the incretin effect, which is where we get this A1C or glucose lowering effect better with oral versus intravenous. And so the benefit of that is that that effect only takes place in the presence of glucose that's just been introduced into the system. So if a person has a meal, then their body recognizes the glucose and will start producing GLP-1, or in this case, if we're giving them exogenous GLP-1, they will be able to start acting and bringing that sugar into the blood, or into the cells rather, where it belongs, and getting it out of the blood. If the patient takes their GLP-1 and then does not eat, their GLP-1 will not cause their blood sugar to go down. So we don't really see hypoglycemia with GLP-1s unless it's in combination with insulin and other things like that. So that's great.
Yeah.
So we also have weight loss associated with GLP-1s, which is also huge. Which is
opposed to insulin, which is going to cause weight gain. And do sulfonylureas cause any weight gain?
I
think it's negligible either way, but either way, insulin definitely causes weight gain.
Yes, although that's reduced if they're taking with metformin by about 3 kilograms per the home trial.
There you go.
Fun facts. So the GLP-1s will help you lose some weight. In fact, there's actually a version of liraglutide, which is Victoza when you're using it for diabetes, but there's a 3 milligram version that's approved for weight loss called Saxenda. So that's approved for patients that don't have diabetes, again, because it doesn't activate unless you eat.
Right.
But it's used specifically in weight loss. But what it does is it slows gut motility so that you are not emptying your stomach quite as quickly. And it also curbs appetite, so they can bind to areas in the hypothalamus. I think it has something to do with like the pro-opiocortin or melanocortin neurons firing, something like that, in the brain. And so it will cause the hypothalamus to basically increase satiety. So you'll have a feeling of fullness after a meal, and the patient stays full longer, and so they don't feel the need to eat. And so you'll see similar effects with things like Contrave that have Wellbutrin and naltrexone combination. You're kind of working on that similar pathway. So decrease in gastromotility and curbing of the appetite, increase in satiety, all aid in the weight loss process. So these drugs, especially in an overweight patient, are a good option.
Yeah, and so we've got low risk of hypoglycemia, which, like I said, GLP-1s weren't used on a lot of these trials. We also have weight loss, which is just overall going to help your control and decrease your risk for other other events like cardiovascular events. And we also have some good data to say that there can be some cardiovascular benefit when you use a GLP-1, which is opposed to sulfonylureas, which it's questionable, but potentially there could be some cardiac detriment with sulfonylureas. So that's definitely not really something we want to risk when cardiovascular events are frequently what kills patients with diabetes. And that's what we're worried about, that whole death thing.
Yes. So which GLP-1 is your favorite, Cole?
So if I had to pick a favorite, which there's three that we'll talk about, but Victoza is probably my go-to. It is once daily, which isn't ideal. It's an injection. But there was a trial called the LEADER trial, which showed good cardiovascular benefit when you use Victoza compared to placebo, as opposed to some of the other once dailies, which they've studied, and the data didn't really come out the way they wanted it, but it did for Victoza, so that's probably my go-to.
Yeah. So there's one that's twice daily, which is Byetta.
Right.
Extended. I don't know who uses that anymore. That was the first agent, and it's cool as far as a new novelty agent, but I'm not a big fan of that one, especially with it being twice a day. We don't have the cardiovascular benefits from it, and so I definitely would prefer Victoza if you're going to use a daily use GLP-1. There's also Adlixin, which is lixisenatide, also approved now. It was in Europe for a long time, and now it's approved in the States as well. I don't see too many people on that, if anyone, and not a huge fan of that either, because they tried to show cardiovascular benefit with that and didn't get any benefit. No difference between that and placebo, which was pretty funny because they spun it in a way of like, well, it doesn't cause harm, so that's good news. So that was kind of funny. But yeah, so Victoza is definitely the go-to for once daily. Now, Bydureon is the first, which is extended release Byetta, basically exenatide.
Yeah.
And so the Bydureon was the first one that came out that was once weekly. And so for some patients who don't want to use a daily injection, the once weekly option does seem a little better. The original Bydureon pen that delivered the the injection was very cumbersome, and it was like 8 feet long, I think. And it was, you had to shake it. This is not a joke. You had to shake it 80 times to reconstitute it. That's actually in the package insert. Check it for particles and then reshake it another 80 times.
And not only that, but it's very painful to inject.
Yeah.
A lot of patients complained about it.
I would have definitely lost track trying to shake something 80 times. I would have done an average of 65 shakes. And so the Bydureon wasn't great. They did the duration trials and saw that it was actually inferior to Victoza as far as A1C lowering, so also not great. And then there was no benefit when they looked at cardiovascular benefits either. So inferior to Victoza, and it is truly inferior. So it didn't. Not only did it not meet the criteria for superiority, which is what they were going for, but it actually didn't even meet the criteria for non-inferiority. So Victoza is a better drug for A1C lowering and for weight loss. So the next one was Tanzium, albiglutide. That one is being taken off the market now.
Gone.
GSK has stopped the production of it. And that one, again, was inferior. The Harmony 7 trial showed it was inferior to the to Victoza liraglutide. And so I'm kind of glad that one's gone. That was also a pain to reconstitute. Mm-hmm. Such a pain. I don't know who invented that device.
It set in a cup and had to sit there for 30 minutes or something like that.
Yep.
Jeez.
It came with its own carrying cup. That's a lie. But so that one's gone, so I'm glad. And then we had Trulicity, which was my favorite for a long time. That one was actually the Award 6 trial. It met non-inferiority with Victoza. And so as far as A1C lowering, Victoza was still better with weight loss. But as far as A1C lowering, it was just as good as Victoza. Once weekly, the device was awesome, very easy to use. And, it's definitely my go-to.
You never saw the needle, which patients liked a lot, and it was a teeny tiny needle. It didn't really hurt. So a definite positive for Trulicity.
Yeah. One of the things I was a little bit bummed about, at the time was the cardiovascular data wasn't available for Trulicity, and it still isn't. It should be out this year. I'm thinking this summer.
There's the Rewind trials?
Yeah, Rewind trial is what it's going to be, is what it's called. I think the results will be published in June or July, something like that. But as far as A1C going, if someone wanted a once weekly, then Trulicity was always my go-to. But then semaglutide came along, and semaglutide was Novo Nordisk's once weekly GLP-1. And this one met non-inferiority with Victoza. And actually, I think I have to double check myself on this, but I want to say that it actually was superior now to liraglutide, like the Pioneer 4. I think it is something like that. Don't quote me on that yet, but I'll double check and I'll put it in the comments or something. But I think it actually has superiority to Victoza for A1C lowering. And it is compared to Trulicity, and it is superior to Trulicity. And the cardiovascular benefits also showed a benefit as well. The Sustain 6 trial showed a benefit in as far as cardiovascular risk. So, semaglutide, brand name Ozempic, is currently my new favorite once weekly. So I'm now making the switch from
It stole your
Trulicity.
heart.
It stole my heart, my GLP-1 heart. And so Ozempic is the one that I like, and which is weird is because Novo Nordisk actually owns the rights to Ozempic as well. So
Right. And
Novo Nordisk is killing it in the GLP-1 range.
Yep.
They know what they're doing. So yeah, anything to add to that, Cole, that I didn't cover?
No, knocked it out of the park. I think either one of those would be good options. You'd obviously have to consider what this patient's insurance status was and what is going to be preferred or covered. He's on some relatively cheaper medications at this point, so maybe he doesn't have insurance. He would be eligible for Medicare. He's 67, so you have to consider all those things, and GLP-1s are definitely not on the cheaper end. But if a patient has insurance, a lot of insurances are covering them nowadays, so definitely a consideration.
And I'm not saying that I wouldn't use Trulicity either, because Ozempic is so new. It's probably not on a lot of formularies yet. And so I definitely would still use Trulicity. You're going to run into cases as well where the person wants a once weekly and the preferred agent is Bydureon. So, one, they do have a new device out now that makes Bydureon much easier to use, but it's still obviously inferior. So the drug's still the same, inferior to Victoza. But if that's all the patient can afford, it's still going to lower their A1C.
Right.
So I'm not saying that you should never use those. I'm just saying my preferred agent in a perfect world of insurances staying out of the clinician's business, then the Trulicity and semaglutide or Ozempic would be my top two once weekly. But Bydureon should still be an option if that's all the patient can afford, because you still will get good A1C lowering. And I'd rather use that than some of the other ones on the market.
Yeah, and we addressed the cost issue a lot. Which we're sitting here with Beats headphones on, sitting in a podcasting room, so we're living in the perfect world when it comes to recommendations. So we go for what would be ideal, but you've got to work with your patients, and you've got to work with what they want and what they can afford, or they're not going to use their medication, and there's no reason to prescribe it. And some patients actually prefer once daily injections too, because they're concerned that they're going to forget. So most people you would think would just want to inject once a week, but some people, they're like, oh, I'd like to stay on a good regimen every day, so I'd rather inject once a day. A lot of considerations.
Yes. And, if you're done Beats shaming me now, I will also bring up the Dpp-4 inhibitors. The thought process, I saw this recently, so I at least want to address it. I have never seen really any good data. I think there's one trial that I saw that used exenatide and Januvia together, which I wouldn't have. I would use a different agent if I was going to use that combo anyway. I would have used Victoza or something. But there's not really great data for using a GLP-1 and a Dpp-4 inhibitor together. The thought process, at least in my mind, is, and if you're a endocrinologist and you want to correct me, that would be great, because then I can learn something as well. But in my mind, in physiology, what's going on is your natural GLP-1 is very short-lived, and so one of the reasons that it gets broken down so quickly is your dipeptidyl peptidase, your DPP-4 enzyme, is breaking that down. So if we inhibit that enzyme, you're allowing your natural GLP-1 to flourish. But the GLP-1s that we are giving, the analogs, those are already resistant to the effects of DPP-4. So by adding on a DPP-4 inhibitor, we're not really accomplishing a whole lot, and they're probably just going to give the person more constipation and upset stomach. And I've never seen any of the guidelines. Like, if you look at the guidelines where they talk about adding on a medication, I don't think that they have DPP-4 added or listed as an option to add onto a GLP-1. And I've never, again, I could be wrong about this. I haven't done like an exhaustive search or anything, but I've never seen any good data that shows them together.
No, I'm not an endocrinologist, but that's
What?
my understanding. Yeah, I know, right?
This whole time.
I know. I've just been lying to you. But, I mean, that's my understanding of it, too. And, whenever I see, which does happen occasionally, a patient on both, it just seems a little redundant, especially because, in general, DPP-4s aren't going to give you much A1C lowering anyway, and they're pretty expensive as well. So, when you're thinking about the patient's best interest, it's probably best that they either just not have it or be on something different.
Yeah. Probably get twice the A1C lowering with a GLP-1.
Right.
Average speaking.
Which I think they're working on an oral GLP-1,
They are. Yes, semaglutide.
Yeah, semaglutide. There you go. Novo Nordisk. They
Killing
also
it.
have some free information, good diabetes patient information,
it's
right?
excellent. And by the way, we're not sponsored at all by Novo
No.
Nordisk, so if you're a rep,
But we're not opposed to it.
Yeah, yeah. So if you're a rep for them, you're welcome.
Right.
But Novo MedLink, I think, is the website.
Yeah.
Talk to them because they actually make money off of it. But it's free for healthcare professionals to give to patients. They're very, very good. The only time I will make recommendations on here, even if they were trying to sponsor us, would be if I use them myself. And I do use these products for my diabetes patients that I see for the AmCare type program that I'm with, and they're excellent. And so I give them to all my patients, and it really helps with carb counting and understanding A1C and different goals and things like that.
Awesome. So finishing up with this patient, we want to increase his metformin, potentially get him on a GLP-1 if that's a good option for him. So what about his blood pressure? We want to mess with that at all?
So his blood pressure right now is 155/93.
Okay.
So the JNC8 would recommend 150/90, and because of his age. However, we don't like JNC8, at least we don't. If you do, sorry. I'm much more of an advocate for the new blood pressure guidelines, and they would put him, even at his age, would put him at 130/90.
Mm-hmm. And other guidelines are falling in line too.
Yes.
For instance, the ACE guidelines are now recommending 130/90 as well. So it does seem like that's a reasonable, at least long-term goal for him to get to.
Exactly. And if you have questions about using that in patients with diabetes, because you're thinking, well, didn't the Accord trial show a harm, no benefit?
It
from
did.
lowering?
We just talked about that.
No, but we didn't talk about blood pressure, did we?
Oh man, dang it.
So
Left that out.
unbelievable. We did talk about it, I think, in the first podcast, though, so I won't go through it. But basically, read the Accordion review. It's a very good summary of why the blood pressure arm of the Accord trial maybe wasn't all that great. It was a 2x2 factorial trial, and so they're thinking that the A1C lowering group could have negatively impacted, because it was the same patient population. So some of the patients that were in the more intensive blood pressure lowering group were also in the intensive glucose or intensive A1C control. And so the thought process is maybe those results from the intensive A1C could have decreased the actual benefit or masked the benefit of the blood pressure being lower, because we did see a decrease in stroke with the intensive glucose group, decrease intensive blood pressure lowering.
Yeah, and check out our first podcast for that. I think it's pretty good. We probably stumbled over our words a little bit. It was numero uno, but
Yeah.
A good review of the new blood pressure guidelines.
Yes.
And what the recommendations are.
I think it was voted number one review of 2018.
Podcast review, yeah.
Maybe or 2017. I don't know when we recorded that. Whatever.
I dare you to find another podcast review of those guidelines.
There's probably 18 of them. They're all ranked way above us.
Uh-huh.
So anyways, the blood pressure goal for this guy would be, in my mind, 130/80, if he could tolerate it. There's always exceptions to the rule, as always.
Yeah, I think I said 130/90 before, but I definitely meant 130/80.
Yeah, I think actually, no, I said 130/90 for sure. So
Okay.
I meant...
We are now correcting ourselves. 130/80.
So, so the ACE guidelines now are saying the same thing, echoing the new blood pressure guidelines. The issue that I have, even if this person had perfect blood pressure and we didn't want to do anything, the issue that I have is the patient is on a calcium channel blocker, and they are now spilling protein in the urine. So because we have proteinuria, we have to start considering maybe what's causing that, other than just the patient having prolonged diabetes. And so the way to think about amlodipine mechanistically is its effect on the kidneys. To think that it dilates the afferent arteriole, which is feeding into the glomerulus. Efferent arteriole is allowing blood flow to exit. So you're getting dilation of the afferent arteriole, but nothing on the efferent arteriole. So you are increasing intraglomerular pressure and potentially causing proteinuria. So if this person had perfect blood pressure, I would probably suggest stopping the amlodipine and switching to an ACE or an ARB. ACE and ARBs will dilate the efferent arteriole, and so you will get that decrease in interglomerular pressure and allow the blood flow to be a little bit more of an easy process, and you can hopefully stop them from spilling protein.
Sure.
And so if we, in this case, because we have to add on an agent because we want to get his blood pressure a little lower, we could add on either an ACE or an ARB. To make it easy, if he didn't want to take another medication, then we could just give him generic Lotrel, which is benazepril and amlodipine. And
it's not expensive.
Not expensive anymore. If he is okay with taking two different medications, I would probably give him amlodipine in the morning, and then I would probably give benazepril or lisinopril at night. And just based on the renal protective properties of the ACE, the MicroHope trial was dosed at night, and then MAPEC, which was a small trial, and that only included patients with 3 or more meds, but that one showed a benefit when one of the agents was dosed at night as well, which, if you think about it, the RAS system is more active at night, so it would make sense to dose the ACE.
Makes sense to me.
And that way, you don't have to worry about whether a person's a dipper or a non-dipper.
Right.
And you can cover all your bases. And so the blood pressure would hopefully go down a little bit, monitor his renal function, look for any kind of AKI, and then also his potassium if you're adding on an ACE. But
yeah, and if it seems like we've touched on these things before, we probably have, but we reiterate them because they're important.
Plus, we also don't listen to our own podcast, so we don't know what we covered.
So we don't know what we did. But we're probably going to come back to diabetes as well, so we're just focusing on this guideline today. But diabetes, there's a lot to it. It can be easy, but it can also be complicated. So I'm sure we will have future diabetes podcasts.
Yes, maybe a ton more because we'll just have to recycle topics.
Basically.
So because we don't know a lot.
Anyways,
so that's this patient, and then I think adding an ACE would be beneficial for his kidneys and his blood pressure. Adding the GLP-1, maybe Ozempic or Trulicity. And then atorvastatin, I would leave alone. If he's getting older, but still, high intensity statin would be where I would want them because of the increased chance of having issues with cardiovascular events, being that he has diabetes and hypertension. His ASCVD risk is probably quite high. As far as aspirin goes, because that might be another thought process. He's 67. The sweet spot for primary prevention is really 50 to 59, and then outweighing the risk versus benefit, 60 to 69. And we can decrease the chance of having cardiovascular event and colorectal cancer, but we typically think 10, 15 years.
It's about 10 years, at least.
Out from the patient starting it. So is this patient able to take aspirin every day for 10 years? And because he's already 67 years old, I probably wouldn't risk it, but be something to consider. If he'd already had an event or something, if he'd already had a stroke or TIA, maybe would be a lot better candidate. But in this particular patient, wouldn't be too worried about it.
Right. And interestingly, the benefit is really only there while you're taking the aspirin. So if you hit 70 and you're like, okay, I'll take it off, which is reasonable, then it's not like a long-lasting benefit type of thing. So.
Yes. So, yes, that's anything we want to add? I mean, we can ad-lib all day if you want.
Yeah, we could. But, these people, I'm sure they get tired of it after, how long are people's attention spans? Like 7 minutes?
7 minutes. I think we're past that.
Yeah. So we basically had to wake you up every 7 minutes times 5.
With our charismatic and charming personalities.
Yeah, absolutely. So we can wrap it up. I don't have anything else for this guy.
All right. So that is the patient KJ. And we can post a copy that's
Sure.
pretty short.
Super simple. Yeah.
Post it online if you guys want to check it out on the website. Feel free to leave any comments or likes. We also appreciate likes. And, ratings on iTunes and all those help us. We are on Spotify now. If you're happening to listen to us on Spotify, then you're a pioneer. Because we just got on today, actually. We got the email right before we started the podcast. That was cool. And reach out to us if you have any questions. We're on all social media platforms, or you can reach us by email. You can reach me personally, mcorvino, CORVINO, @coreconsolerx.com, and give us any feedback. Or if you want to be a guest, by all means, reach out, and we will consider your application. And join us next time. Y'all have a good one.